This conference will now be recorded.
All right. Bleeding is pathophysiology, assessment, and management of bleeding and fluid resuscitation. So when blood comes out and trying to get volume back. Obviously, there is no replacement for blood, but we can use fluids, lactated ringers and normal saline, to attempt to replace some of that fluid. Pathophysiology applies comprehensive knowledge of the pathophysiology of respiration and perfusion to the patient and assessment and management. Bleeding can be one of the most time-sensitive conditions. It can be external and obvious or internal and hidden. It can cause weakness, shock, and ultimately death. Excuse me. Physiology and perfusion. Perfusion is the circulation of blood within an organ or tissue in adequate amounts. Hypoperfusion or shock. Cardiovascular system fails to provide sufficient circulation for blood parts to function. Emergency medical care is designed to support the brain, spinal, heart, lungs, and kidneys. The cardiac cycle, repetitive pumping process. It begins with the onset of cardiac muscle contraction and ends with the beginning of the next contraction. Preload is the amount of blood returned to the heart to be pumped out, and the afterload is the pressure in the aorta or the peripheral vasculature resistance, PVR, against which is the left in the against which what is left in the ventricle must pump blood. Stroke volume, or SV, is the amount of blood ejected per contraction. The cardiac cycle is connected to the bleeding and shock through the relationship of blood pressure. Delivery of oxygen to the tissue is dependent on an adequate heart rate, stroke volume, hemoglobin levels, and arterial oxygen saturation. Hemorrhage is the discharge of blood from the blood vessels. Bleeding can range from a nicked capillary to a severely spurting artery. External bleeding is controlled by using direct even pressure, pressure dressings, splints, hemostatic agents, tourniquets, and pressure bandages. What is a common hemostatic agent that a lot of us think of right away? Good, Justin. Quick plot. Does anyone know what a hemostatic agent is, or does anyone not know what a hemostatic agent is? I think that's a no. External hemorrhaging results in the break of the skin. Extent or severity is often a function of the type of wound and types of blood vessels involved. Internal hemorrhaging, it may appear in any portion of the body. It's non-traumatic. Internal hemorrhaging often occurs in cases of GI bleeding, ruptured ectopic pregnancies, ruptured aneurysms, and other conditions. Mechanisms of injury for internal bleeding: falls, blast injuries, automobile and motorcycle crashes. The natures for internal bleeding. Excuse me. The nature of an illness for internal bleeding: bleeding ulcers, bleeding from the colon, ruptured ectopic pregnancies, and aneurysms. Signs and symptoms: pain, swelling in the area, distension, bruising, dyspnea, tachycardia, and hypotension. Hematoma, Other signs and symptoms: hematuria, hematemesis, melena. I'm going to butcher those. I'm not going to even try. First signs is generally a change in mental status. Substantial changes and vital signs occur for approximately 2 pints, 1 liter of blood loss. Hemorrhagic shock results in inadequate perfusion and even death. Considered serious with a significant mechanism of injury, poor general appearance, signs and symptoms of shock or hypoperfusion, rapid blood loss, and uncontrollable bleeding. Bleeding tends to stop quickly in response to internal clotting mechanisms. Hematostasis, platelets plug the hole and seal the injured portion of vessel. Medications can interfere with normal clotting. A patient with hemophilia should be transported immediately. What type of medications are they referring to with what can interfere with the normal clotting?
Blood thinners.
Okay. Does anyone know some of the most common ones we're going to see, whether brand name or generic?
Coumadin, warfarin, Plavix.
Okay. Good. Um, those are one of the ones that you guys are gonna want to definitely take down, and whatever you can think of. And yes, aspirin is still technically a blood thinner. Like Matt said, ASA. Know both the generic name and the brand name. So know that Xarelto and Apixaban are the same thing. It's either Xarelto or Eliquis. But knowing both those names can also help you because the patient may be using the generic version of it. And if you only know the brand name of it, you might not catch it being a blood thinner. Trauma triad of death, combination of hypothermia, coagulopathy, and acidosis increases mortality. Coagulopathy can result in further hemorrhage. Identify the conditions of hypothermia, coagulopathy, and acidosis in the setting of a trauma and intervene wherever possible. Scene size up. After the scene is safe, take the appropriate standard precautions. Blood will look different on different surfaces. Determine the nature of injury or the mechanism of injury. Consider the need for additional resources. Primary survey. Search for the life-threatening bleeding. Be aware of obvious signs of injury and distress. From a rapid full-body scan of the patients, follow the XABCDE mnemonic. Determine the level of consciousness. Any internal bleeding must be treated promptly. Determine how fast transport decisions should be made and where the patient should be taken. History taking. Investigate the chief complaint and be alert for signs or symptoms of other injuries due to the mechanism and or nature of injury. Carefully assess the mechanism of injury in a trauma patient. Gather the information on the patient's chief complaint using the OPQRSTI mnemonic and obtain a sample history. Secondary assessment. Uncover injuries and illnesses that may have been missed. record vital signs, complete a focused assessment of the pain, and attach appropriate monitoring devices. Assess respiratory, cardiovascular, neurologic, and musculoskeletal systems. Obtain baseline vitals and use monitoring devices. Reassessment. Assess the effectiveness of any intervention. Obtain patient's vital signs every 5 minutes en route to the ED. Recognize, estimate, and report the amount of blood loss. With internal bleeding, describe the mechanism and nature of injury and the signs and symptoms. External hemorrhage can be managed with direct pressure combined with pressure dressing and or splints. Use of a tourniquet is preferred for uncontrollable external bleeding in an extremity. Provide high flow oxygen and assist ventilations if necessary. Direct pressure can control most instances of external bleeding. Apply pressure over the top of a sterile dressing. Create a pressure dressing. Stretch the bandage tight. If direct pressure fails, consider applying a tourniquet or wound packing with a hemostatic agent. Wound packing creates an internal pressure dressing. Hemostatic agents, they cause enhanced clot formation in a wound site. It dehydrates the blood or undergoes a chemical reaction that stimulates the blood's natural clotting cascade. Tourniquets are useful if the patient has a severe hemorrhage from an external injury below the aorta, below the axilla and groin. Commercially available tourniquets: the CAT tourniquet, the soft T, the ratcheting medical tourniquet, and the SWAT T. Most of us are going to be using the CAT tourniquets. Those are what are usually seen as the best in the business so far. This could change with more studies, but most of what I've seen on the ambulance are going to have CAT tourniquets. Just make sure you know what your service uses. The last thing you want to do is find out how you use it when you need to use one. These are different ones. You have a CAT tourniquet up at the top. SWAT T is down below. A tourniquet is typically released at the hospital. If a commercial tourniquet is not available, use a triangular bandage and a stick or a rod. Splints. Air splints can control the bleeding associated with severe soft tissue injury. Rigid splints can help stabilize fractures. Pneumatic anti-shock garments. Inflatable devices that cover the legs and abdomen, rarely used, always follow local protocols. Hemorrhaging from the nose, ears, and mouth can be caused by skull fractures, facial injuries, infections, tinnitus, nose drop use and abuse, dried and cracked nasal mucosa, high blood pressure, coagulation disorders, and digital trauma. Internal hemorrhage. Definitive care includes rapid transport to the ED, treatment of shock, minimizing movement of the injured part, and rapid transport. Ultrasound may be used to locate the bleeding, give nothing on mouth, keep patient warm, and monitor serial vital signs. Management of hemorrhagic shock. Focus on exsanguinating hemorrhage first. Take the standard precautions and ensure the scene is safe. identify and try to stop any major bleeding, and quickly evaluate the patient's hemodynamic status. Establish and maintain an open airway. En route, insert at least one, preferably two, 18-gauge peripheral IV lines. Management of hemorrhagic shock. Obtain IV access at the scene only if transport is delayed. Administer isotonic crystalloids of normal saline. Monitor the level of consciousness, pulse, and blood pressure. That didn't take too long, guys. Unfortunately, that's all we have for tonight. I'm glad. I hope everyone, pretty sure everyone's happy about that.